It's now my pleasure to introduce Dr. Carl Insogna. Throughout his career at Yale, Dr. Insogna has been funded to do both clinical and translational research. He began his clinical work as a fellow studying hypophosphatemic disorders, specifically X-linked hypophosphatemia and renal stone disease. He was the first individual to show evidence for renal phosphate conservation in patients with XLH, despite the defect in renal tubular phosphate reabsorption. He was also the first individual to clarify the relationship between serum phosphate and absorptive hypercalciuria in patients with calcium oxalate stone disease. His work in hypophosphatemic disorders has continued uninterrupted over the last 30 years. He has worked closely with Dr. Thomas Carpenter of pediatrics to explore the natural history of XLH and has undertaken a variety of studies aimed at developing new therapies for this skeletal dysplasia. He is currently lead investigator for a multi-center international study evaluating the role of neutralizing antibody to FG23 in the treatment of this disease. He has had experience with hereditary hypophosphatemic rickets, with hypercalciuria, and has published in this disease. So welcome, Dr. Insogna.
It's a great pleasure to be here, and I'd like to thank the organizing committee for allowing me to participate in this really important symposium that allows caregivers like myself, members of regulatory agencies like the FDA and other stakeholders to hear firsthand from patients with this disease, to hear about what it's like having this disease in different parts of the country at different stages in your life, so that we can collectively come together and think about ways that we can lessen the burden of this disease. So my charge this morning is to provide an overview of FGF23-mediated hypophosphatemias. So you'll remember that the introduction mentioned the fact that I've been doing this for 30 years. So holster your iPhones, put away your iPads, take off your Beat headphones. And just like I did so many years ago in that little red schoolhouse way out on the windswept prairie when Willa Cather taught me the 3 R's, take out your slate writing tablets, dip your quill in the ink, school is in session. So what we're going to try to talk about is what is FGF23 and how does it regulate blood phosphorus? Why does too much FGF23 cause bone problems? What bone problems does too much FGF23 cause? What diseases are associated with too much FGF23? And how is overproduction of FGF23 treated? So fibroblast growth factor 23 is made in cells embedded in bone called osteocytes, and they make FGF23. And an important feature of the way they make FGF23 is that it's produced inside the cell, but then the cell decides how much the body needs. And depending on how much it needs, it either makes the active hormone, which has got 2 pieces, or it cuts it in half and secretes the 2 halves, which are inactive. So the final regulation of this hormone in the blood is made after the hormone is made in the cell, when the cell decides how much you really need. And if you don't need much, it chops it in half. If you need much, it doesn't chop it in half and lets the whole molecule be secreted. And it acts in the kidney, and in the kidney, it acts to reduce the ability of the kidney to reclaim phosphate. So much of the phosphate we eat, we pee right out. Just as soon as we pee it out, we reclaim most of it. And how effectively we reclaim it dictates what our blood phosphate is. And the way the kidney reclaims that phosphate is by opening little ports on the kidney that allow the phosphate to come back in. And what FGF23 does is close those ports so you pee out more phosphate, and in doing so, you lower your blood phosphate. The other thing it does is inhibit the synthesis of the active form of vitamin D, which is called 1,25-dihydroxyvitamin D, and that is made in the kidney. And FGF23 inhibits the production of that active form of the hormone by inhibiting the step that makes it and stimulating the step that breaks it down. And the net effect of that is lower levels of this active form of vitamin D, 1,25-dihydroxyvitamin D, and that is important for absorbing phosphate from your intestine. So FGF23's main job is to defend your blood phosphate, to make sure it doesn't go too high. And it does that by having you pee out a lot of phosphate and absorb less from the intestinal tract. Now, when there's too much FGF23, it adversely affects bone. And bone is actually a pretty complex tissue. It has multiple parts. So there's a hard outer shell of bone called the cortex. There's this trabecular bone, this sort of spiculated bone in the middle that you see when you crack open a chicken bone. That's where the bone-forming cells are made. And then there's this thin, smooth surface that lines our joints called articular cartilage. But cartilage is also present in growing bone, and it's where bone grows. And it's that cartilage that's affected by FGF23 excess, as we'll see. So the two tissues in bone that are affected by FGF23 are the mineralized tissue itself, both cortical and trabecular, and the articular cartilage, and the cartilage. So excess FGF23 leads to renal phosphate wasting and a chronic low blood phosphorus. And it does it by the same mechanisms that it usually uses to control your blood phosphate, but it does so in excess. So again, it closes the ports on the kidney, so you pee out too much phosphate, and that lowers your blood phosphate. It inhibits production of the active form of vitamin D, which is also made in the kidney, and that impairs phosphate absorption, so you don't absorb as much of the phosphate that you eat. You're peeing out too much, you're not absorbing enough, bad condition. It's also important to point out that when you suppress this active form of vitamin D, you also impair the ability to absorb calcium. So it's a double whammy. Your phosphate's low and you're not absorbing calcium. And that leads to rickets and osteomalacia, which are the two conditions we're going to talk about that affect the two components of bone that I mentioned. Rickets reflects the problems that are developed in the cartilage at the growth plate, and osteomalacia reflects what happens in the mineralized tissue of bone. So again, what's happening is that in FGF23, you've basically punched a hole in a bucket. So you're trying to fill the bucket, that is your bloodstream, with phosphate, but it keeps leaking out at the kidney because of those pores being closed. So our therapies to date have had the problem of sort of trying to fill the bucket and not being able to fix the hole. Chronic phosphate wasting and hypophosphatemia causes a defect in normal cartilage growth that results in an abnormal growth plate. So the growth plate is the place where the bone grows. It is a very complicated cartilaginous structure. It's sort of like building a skyscraper. It's the place where the bone grows longer. And it grows longer because the cells in the growth plate have very distinct roles. So the cells at the top of the growth plate are starting to expand and proliferate. The cells at the bottom of the growth plate are actually dying. They go to the big chondrocyte corral in the sky. And they have to do that because the bone has to come in and replace those dying chondrocytes. And in fact, the dying chondrocytes help to call in the bone-forming cells. So the structure of a growth plate is shown in the lower left in the purple. These are the cells that are proliferating, called hypertrophic chondrocytes. Those are the ones that are expanding, make the bone grow. On the right is shown what happens when you don't have phosphate around. Phosphate is a key signal that changes these proliferating chondrocytes into chondrocytes that are going to die. But you can see over here, they're just all still happily proliferating, which sounds like a good thing, but it's not a good thing, as we'll see. They don't have the signal to stop growing because phosphate is that signal. And so what does that lead to? That leads to rickets in childhood. So the abnormality leads to rickets in growing children, which all of you know presents as swollen wrists, bowing deformities of the lower extremities, and bone pain. So on the top two panels, we see this is a normal radiograph of a child's wrist, and you can see these nice clear dark lines. You can't see the cartilage. It doesn't show up on an x-ray. But you can see how nice and sharp these lines are because those are normal growth plates. Over here, we see that the growth plate is fuzzy and indistinct. That's because this normal process of mineralization has gone awry. Here's a child whose legs don't look that bad, but when you take x-rays, you see that they have marked bowing deformity, and that's again because these growth plates are not functioning normally. Here's a child with knock knees, again for the same reason. So genu valgum, genu varum, both conditions associated with an abnormal growth plate. So in the mineralized tissue, a different problem arises. In the mineralized tissue, when you don't have enough phosphorus, you can't mineralize bone. What does that mean? We make bone in a two-stage process. We lay down a sort of putty-like scaffolding that's called osteomalacia, and then we pour mineral into that to harden it up. If you don't have enough calcium and phosphorus, you can't harden up that scaffolding. That scaffolding is called osteoid, and when it builds up in bone, it makes the bone weak, and it builds up both in that trabecular compartment that we talked about in the middle of the bone and in the cortex of the bone. There are yellow arrows that point to the osteoid, which is the red stuff. The green stuff is the mineralized bone. The light red stuff is your bone marrow, but all the dark red staining stuff is osteoid that should have been mineralized but was not. And this biopsy is riddled with that, and it's important to note that it's in the cortex because the cortex is very important in the bones of your lower extremities to prevent fracture. And as you know, people with XLH often fracture in their lower extremities, and it's because the cortex is poor quality, in part because of that osteomalacia. In contrast, over here on the left, we see what looks like normal bone. Now the staining is different. Here the light purple is the mineralized bone, and the very light, which you really can't see, is osteoid. That's because normally you shouldn't have very much unmineralized osteoid. So when it starts to accumulate like it does in hypophosphatemic disorders, that's not a good thing, and it impairs the mineralization ability of this bone. So this is what it looks like normally. Normally we just have a very thin layer of osteoid with lots of new bone forming beneath it. And with osteomalacia, you have this thick glacier of unmineralized osteoid and very little new bone formation because the cells that need to form that bone can't penetrate this thick layer of osteoid to get down here to make new bone. And so what does osteomalacia lead to? Osteomalacia leads to fractures. This patient obviously has lots of problems besides simply this insufficiency fracture, but that thin dark line there is an insufficiency fracture that occurs despite the fact, obviously, that this person has a plate in place. So now let's talk about the disorders that are caused by excess FGF23, and I've divided them into three parts. First are genetic disorders where the gene is known, the offending gene is known, is present in all cells, and a relationship between the gene and the disease can at least be surmised. And by that I mean, in most of these conditions, we think we have some idea how it relates to the disease. We don't really know. There's one exception that I'll mention. And these would be considered inherited diseases. These are ones that can be passed on from parents to children. And the poster child for that, of course, is X-linked hypophosphatemia. The gene involved is PHEX. Probably the condition where we understand best the pathogenesis is another inherited disorder called autosomal dominant hypophosphatemia. There, the disorder is the gene mutated as FGF23 itself. And then there are three incredibly rare disorders: autosomal recessive hypophosphatemia types 1, 2, and 3, rare as hen's teeth, no pun intended, where the genes are listed, DMP1, EMPP1, and FAM20C. And then there's this even more rare disease, osteoglyphonic dysplasia, which I've actually never seen a patient with, due to a mutation in FGF, the receptor for FGF23. Then there are genetic disorders where the gene is known, is not present in all cells, and a relationship between the gene and disease is unclear. And that includes fibrous dysplasia, epidermal nevus syndrome, and we won't touch on those. The genes that are associated with them, at least in the affected tissue, are shown there. And then finally, there are diseases that are not genetic, that are acquired. And the one disease I'll mention is tumor-induced osteomalacia. In that disease, the tumor itself has a peculiar genetic abnormality where two genes are fused together. People think that this may somehow play a role in the pathogenesis of that disorder, but that is, at this point, speculative. So again, we'll be talking about autosomal dominant hypophosphatemia, tumor-induced osteomalacia, and X-linked hypophosphatemia. So autosomal dominant hypophosphatemia is autosomal dominant hypophosphatemia rickets is due to a mutation in FGF23 itself, as you may remember. Normally, the production of FGF23 protein, as I mentioned, is regulated by intracellular cleavage of the protein, not by controlling how much is actually made. A mutation in the cleavage sites disables this regulatory mechanism. So again, the cell makes the protein and then decides how much you need, and if you don't need much, it chops it in half and secretes the inactive fragments. But in autosomal dominant hypophosphatemic rickets, there's a mutation at this cleavage site So the cell can't cleave it. So that regulatory step, which is a key regulatory step, is lost. The more you make, the more you secrete from the cell. And that leads to excess circulating amounts of FGF23. So every time production of FGF23 gene goes up, the cell releases more active FGF23. What are the manifestations? They're very similar to X-linked hypophosphatemia, rickets and osteomalacia, fractures and pseudofractures, but it's a little more variable in its presentation, sometimes not detected until late childhood, even adolescence, and rarely even young adulthood. Dr. Emmel had some interesting data presented earlier this week that suggests that iron deficiency makes the disease worse, and in iron-deficient patients with this disease, iron pills seem to improve the disease. Now, what about X-linked hypophosphatemia? This disorder is due to a mutation in the gene FEX. We still don't understand why it is that when you have too much FEX, or when you lose function in FEX, you make too much FGF23. We do know they're both in the same cell. FEX doesn't directly regulate FGF23, but somehow when you mutate FEX, you make too much FGF23. And then the same pathophysiology we've talked about a couple of times comes into play. You don't absorb enough phosphate from the kidney. You don't reabsorb enough phosphate in the kidney. You don't absorb enough phosphate from the intestinal tract. You get chronic low serum phosphate. And that leads again to rickets and osteomalacia. In childhood, rickets results in bone deformities of the lower extremities, as we talked about. These are growth curves for children with XLH, showing the different patterns of growth that can occur as a child moves through childhood with XLH. Sometimes they can start low and fall off the growth curve, all different patterns. The bottom line is the combination of defects in the growth plates in the lower extremities and probably defects in the growth plates in the spine lead to, lesser extent in the spine, lead to this disproportionate short stature that is a burden in childhood and remains a burden throughout life. Dental disease is a huge problem in this disorder. And because dental insurance is so terrible and dental care is so expensive, people needlessly lose their teeth, and many patients lose most of their teeth by young adulthood. And why is it that dental disease is so prevalent? We don't know. We know that the teeth are abnormal. Here's a normal tooth. Here's a patient with XLH, what their tooth looks like. There's an expansion of this pulp cavity where the nerve and the blood vessel pass through. We know that not the hard outer shell of bone, which is called enamel, but rather the bone just below it, called dentin, is abnormal in its microarchitecture. We also know that the periodontal ligament that holds the bone in place, that holds the tooth in place, doesn't seem to attach to the tooth as firmly as it should. And as a consequence of that, presumably bacteria get into that space and cause abscesses, which I'm sure many of you unfortunately have experienced. They wax and wane and many times wind up causing tooth loss. In addition to that, lots of patients complain of brittle teeth that fracture, and that may be because the dentin is abnormal. And as I mentioned, fractures and enthesopathy, well, I mentioned fractures, but I didn't mention enthesopathy, are major complications of this disease. So enthesopathy is the calcification of ligaments and joints that limit the range of motion of joints. Here is the hip of a patient like that who could not abduct her legs when she was trying to give birth her child, because she just couldn't abduct her legs because of these entheses. We see it very early in adulthood. It occurs as early as 18 years of age, particularly in the heel bone, the calcaneus. Another complication is spinal ligament calcification. So this leads to chronic back pain, limitation in range of motion of the joints. Degenerative joint disease of the spine is common, but also this peculiar calcification of normally non-calcified ligaments that run in front of the spine and run in back of the spine. And the ones that run in the back of the spine are abutting the spinal canal. And I've actually had a patient who developed weakness in all four extremities when he was thrown to the ocean floor swimming and had to have emergency decompression surgery because these calcifications were impinging on his spinal cord. Finally, hearing loss is a major problem in patients with XLH. It affects the middle ears of the bone, but probably also affects the cochlea, which is the place where the sound is transduced to, and also the site where balance is regulated. And so a lot of patients have symptoms that are very reminiscent of Meniere's disease, dizziness, ringing of the ears, as well as hearing loss. Tumor-induced osteomalacia is due to overproduction of FGF23 by small, often very difficult to detect, usually benign tumors called phosphaturic mesenchymal tumors. They can be anywhere in the body, in the nasopharynx, in any bone, in soft tissue. Dr. Jan de Boer, sitting in the front here, is an expert in this disease. Usually goes undiagnosed for years. Patients often present with many pseudofractures, profound weakness, and are very disabled. Surgical resection, when possible, results in immediate cure. And one of the interesting things is that patients with tumor-induced osteomalacia will have serum phosphates as low as patients with XLH. And patients with XLH can walk around and function, albeit with difficulty, while the same patient with tumor-induced osteomalacia is incapacitated, can't walk, is in a wheelchair. And it's interesting that somehow lifelong hypophosphatemia, the body makes adaptations to allow you to function pretty well with it. But as an adult or as a child, when you've been used to a normal phosphate and it suddenly drops because of the appearance of this tumor, you're really incapacitated. So this is a patient I saw earlier this year that actually was the focus of an article in the New York Times Magazine this summer, who came to me. She was a jogger, completely incapacitated when I saw her, developed over 4 years. No one could figure out what was wrong with her. She had this little golf ball-sized tumor in the soft tissue of her leg on the left, lit up like a Christmas tree bulb on a special scan called an octreotide scan. We were able to take it out. It's only about 3 centimeters long. Her phosphate before surgery was 1.4. 2 days after surgery, it was 2.9. 4 days after surgery, 2 weeks after surgery, it was 3.7. So rapid improvement. This is a slide that was given to me by Dr. Ward from Canada showing the response of a patient, a young child with X-linked hypophosphatemia, with TIO, who has resection of the tumor at time 0. And you can see that FGF23 falls like a stone. This is the normal range. The serum phosphate rises immediately into the normal range. We often see this overshoot of 125 that's been suppressed all these many years and shoots up with exuberance before it becomes normal again. And importantly, the osteomalacia shown here with all this red now normalizes with correction. For treatment of these diseases, for tumor-induced osteomalacia, treatment is directed at finding the tumor and removing it when you can. For XLH and other causes of FGF23-mediated hypophosphatemia, the treatment has been calcitriol and phosphorus, and that's true for tumor-induced osteomalacia as well. And again, it's an unsatisfactory approach. It's not without efficacy. When done correctly and when patients are able to take it, it does help substantially. But again, it doesn't address the underlying problem, which is you've got a leaky bucket. In April of this year, as you all know, burosumab was approved by the FDA for the treatment of XLH. So at least for that disease, there is now an alternative that has been rigorously evaluated for safety and efficacy. And basically what this blocking antibody burosumab does is let the body heal itself. It blocks the excess FGF23, allowing 125 production to increase, improving phosphate absorption in the kidney. Most importantly, it blocks the FGF23 effect at the level of the kidney and allows improved phosphate reclamation, reduced phosphate excretion, and serum phosphate normalizes. So it's fundamentally different from what we've been doing before. It allows the body to heal itself by blocking FGF23. And it's important to point out that it doesn't block all FGF23 because that would not be a good thing. The developers of this drug were smart. They didn't choose to develop their most potent antibody. They chose then was sort of in the middle range that blocked some of the FGF23, but not all of the FGF23. So what do we know so far about findings with this drug? It improves rickets in children, and preliminary data presented by Dr. Emmel indicate that it is better than calcitriol and phosphorus in a head-to-head trial. In a double-blind trial in adults, compared to placebo, it caused healing of fractures and pseudofractures. In fact, patients taking the drug in the double-blind placebo portion of the trial were 17 times more likely to heal with the drug. After 1 year of treatment, study participants' self-reported stiffness, physical function, and pain improved. And importantly, bone biopsy data indicate marked improvement in the osteomalacia with resumption of normal bone formation. But there's still a lot we don't know, and there's still a lot we need to know. Does every adult with XLH need burosumab? Will it be safe over the lifespan? We've never had a monoclonal antibody therapeutic that potentially could be used from age 2 to age 92. Should there be a hiatus, a break in therapy after epiphyseal closure, like so many of you were told years ago? That is, what about the 19-year-old with XLH, treated her whole life, who's about to go off to college, who says she feels perfectly fine and looks great, and the last thing she wants to do is give a shot every month? Does burosumab completely heal osteomalacia? Does it have to heal the osteomalacia completely, or is partial good enough? Does it prevent all the late complications of the disease? Dental disease, hearing loss, fractures and pseudofractures, enthesopathy. Does it improve muscle function? And how do phosphate and so many other factors regulate FGF23? And are there other therapeutic approaches that can be developed? Thank you.
Thank you, Dr. Alexander.